Alrighty, hello. So it's Linda here with Elrina Van Zyl, who is an amazing pelvic floor physiotherapist and one of the experts who comes into the womenswellbeing.me space to share her knowledge and to empower all of us ladies. Elrina is also an acupuncturist. She's a kinesiologist. She's a women's health expert. She's got fantastic knowledge about nutrition as well. So she's a very holistic practitioner, and because of that, I feel like she brings just so much to the table, and we can learn so much from her. So Elrina, thank you so much for joining today.
Thank you, Linda. It's always a big ego boost having you introduce me. I'm just doing my job, I think. But I think also, you know, the whole world, the word holistic, I often find quite difficult to understand because I really don't understand how we separate the body into bits, because I've yet to meet just an eyeball walking around, you know, or a pelvic floor walking around. So I find it quite hard to think how we separate things out in that way, because it just doesn't work that way. If somebody's emotionally stressed, it has an effect on every cell in their body, has an effect on their breathing, which has an effect on their pelvic floor, you know. If somebody has a scar in their foot, it's going to have an effect on how they walk, which have an effect on the pelvis, which have an effect on the pelvic floor and the breathing. So yeah, I suppose I'm holistic because I've never been able to figure out how to do it in separate little bits.
Yeah. But also you've done training which is bringing together, you know, like the Eastern philosophy as well as a more Western medical approach to our bodies and our minds and our emotions, so which is really quite unique. And so today we are going to talk mainly about pelvic organ prolapse. And just as a little aside, so many women don't actually realize they have a bit of prolapse. Prolapse is when either the bladder or the bowel or the uterus have sort of dropped down or been pulled into or shifted out of their natural positions and might be sort of dropping or pulling into the vaginal canal, or sometimes even outside. But just statistically, over 50, most women will have a degree of prolapse. So this can lead into incontinence issues, discomfort issues. So really worth, if there is anything going on at all down below, you see somebody like Elrina and actually find out what is going on. But Elrina has been part of a very recent new research and new approach to treating pelvic floor prolapse and pelvic organ prolapse. And I just thought it would be amazing to get her on today and get her talking about this. So Elrina, over to you.
Yeah, I'm very excited because I read some of Annie Crowley's work a little while ago, and I was so excited about it because it's when you've been taught that the earth is flat and you've walked around it a few times and you go, but it doesn't appear to be flat, but everybody says it's flat. So you kind of have to go along with that, don't you? And then you've walked around it 3 or 4 times, you go, I'm pretty sure it's round, you know? And then somebody comes and goes, listen, I can prove the world is round. And that's pretty much what she's done for me. She's proven that the world is round. And I did her first course on the sort of biotensegrity approach, which is very much how I work in my musculoskeletal way of working, you know, my fascial release and looking at how everything's connected, you know, everything in the body is connected. And then seeing how exactly that relates to the pelvic floor and specifically to pelvic floor prolapse or pelvic organ prolapse. Because, you know, I've had patients come in and the idea is when the world is flat, that the pelvic floor is weak and therefore the organs are falling out. And then I have a patient come in and they've got a prolapse, but they've got a strong pelvic floor. And then the two things don't really marry up. And I'm like, well, my solution for you here would be for you to go and do some pelvic floor exercises, but your pelvic floor is already strong. So I don't really see how that's going to affect, you know, your prolapse. And then looking at other issues where there's a collagen issue, like a hypermobility issue where a patient has, and most of my patients that come in do tend to have a degree of hypermobility. So the tissues are more stretchy and bendy, they give way easier, they're harder to heal. So that definitely has an effect, which then ties in with the biotensegrity, which means A is connected to B is connected to C, therefore A is connected to C, you know, through this, if you think of yourself being suspended, your bones, your tissues, your organs all suspended in this net of fascia, which is all the connective tissue layers. It goes in through things, around things, through things. And then Anna has just come up with this case study series where instead of looking at pelvic floor strength and prolapse, looking at if a woman has a scar or, you know, biomechanical issue, like, you know, they've got a leg length difference, or they've got muscle weakness on one side and strong on the other side, or some kind of imbalance in the way they move. Is that more effective to treat that for pelvic organ prolapse than perhaps looking at the pelvic floor? And it is. And that certainly has been what I've found. And there's some very exciting research going on at the moment in all of this stuff. So not just in the pelvic floor, but just in how does the whole body work together in this way. So
can I just jump in and do a little, I think this is what I've heard you say, summary. Yes. Is that okay? Just because I know that, you know the stuff so well, and I kind of know the stuff quite well, but we talk on a level, but it's quite nice to be able to just go, whoa, what does that actually mean?
What does it mean? Yeah.
What does it actually mean? So from what I can understand, it means that your pelvic floor muscles can be relatively strong, but if you have got scar tissue, i.e. from an episiotomy, from birthing, or maybe there is tension patterns because your posture's not great, or you've got different leg lengths, you were saying, there's some kind of imbalance in the web of the fascial web that is encapsulating our organs and goes into our pelvic floor and goes right around the whole body, then that, what would we call it, like adhesions or collapse of tissue together, or something that sort of
literally tethering in some cases.
That actually can be causing the pelvic organ pulling or dragging out of their proper places. Exactly. Not necessarily the strength or lack of strength of the actual pelvic floor. Now that is huge, because it is literally, like you say, world is round, world is flat. It is a whole different approach.
Yeah, it gives me goosebumps when I think about it, because you know, I've been doing this for years, and I'm finding, you know, I'm getting results and I'm going, I'm not quite sure necessarily, according to the biomechanical model, the world is flat. Why am I getting these amazing results, you know? But I'm just doing what I'm doing because this is what, you know, I've done musculoskeletal that works. So that's kind of my theory that permeates my women's health practice. And that's definitely made such a difference to the way I work, and understanding why what I'm doing is working in the way that I'm working. Do you know what I mean? It's like, I released that episiotomy scar and her symptoms have gone away. You know, she no longer feels, you know, her organs are falling out when she's running after a child.
So you've actually had practical experience where in clinic you have done myofascial release work around scar tissue of, say, an episiotomy scar, or a
tear, or a C-section, even working around the ribs oftentimes, because I don't leave anything out, you know, you've been to see me, you know, everything gets done. So it's just a question of knowing exactly that ankle that I've released, or that adductor that was so tight that I've released, or that tissue around the ribs that was so sticky, and that she's just moving better, you know, her organs, because look, organs will take their normal anatomical position if they're allowed to do so, you know.
Really, really important, because it also ties in so well with the
an organ or a tissue will take its normal anatomical position when it's allowed to do so. So when you take the stiffness away, when you take the pulling away, when you take the tethering away, that thing will go sit where it would normally have sat, in its normal anatomical position. So if the organ has been pulled out, been pushed out, has been dragged out, if you release that tension pattern through whichever way, whether it's myofascial release, whether it's a postural correction, whether it's a stretching program, whether it's, you know, whatever, the organs will go back to where they belong. Because, and one of Anna's theories is that, is this prolapse the body's way of actually coping in the best possible way for you to still be able to go to the loo? You know, is that the only way? If the body had to adjust to whatever tension pattern there is, it had to push the organ out or pull the organ out in order for you to maintain life, you know, so that you can still breathe and you can still defecate and you can still wee. Wow. So that's an interesting theory, isn't it? Because now we're looking at, that's actually the body's, what's a great word for it, adaptive physiology rather than pathology.
Oh, amazing. And it's that seeking of homeostasis, isn't it? That
absolutely.
You give your body the environment to heal from dis-ease, it will find a way to go back into easeful living or being.
Yes.
So you're saying give the body, adapt the environment back to as close to kind of, not going to say normal, but, you know, ease as possible.
Yeah.
And the organs will follow potentially.
Exactly. And this case study that she does is definitely proving that, because I forget the exact percentages, but in the last study we had on pelvic floor contraction, pelvic floor programs, and this is where the NICE guidelines are based, and a woman should be offered a course of women's health physiotherapy before they offered surgery for prolapse. And that was based on a study where they got a 5% decrease in either severity or symptoms for these patients, you know, so minuscule. But there was 5% of women felt better with it, and there was a shift in the organs. Now, I also don't know, you know, these exercises they did it maybe shift the posture? Were other work also being done, you know, on postural assessments and breathing patterns and scar release work? You know, was it just pelvic floor exercises? I don't know. But in Anna's case, where she's worked on these patterns, tension patterns in the tissue, they had 56% of a meaningful reduction in the pelvic floor dysfunction index, you know, which is
huge, isn't it?
You know, it blows my brain. So
so listeners, just to put this into context, so I listened to a few of this Anna Crowley's YouTube videos and some when she was first revealing this information a while ago now. Elrina is the very first cohort worldwide who has gone through her training. So getting in to see Elrina at this point in time, you're literally learning with one of the few people worldwide who knows this stuff properly. But Anna Crowley is quite a revolutionary pelvic floor physiotherapist and researcher, and she is changing, changing women's lives with this information. And so what Elrina is just saying is that she did, when, you know, this is the kind of stuff that Elrina has been doing and other pelvic floor physiotherapists have been doing. They've been seeing it in clinic. That release work has been instrumental in helping women to heal from pelvic organ prolapse, or at least their symptoms get a lot better. But Anna Crowley actually did a whole clinical case study, and it looks like there has been an improvement in symptoms of 56% of women in her case study, as opposed to only 5% when it's just working with strengthening.
And something to note, Linda, is that if a muscle is dysfunctional, if the pattern is dysfunctional, if you continue to put exercise through those dysfunctional tissues that are already too tight, already too short, this is why, and I've seen this myself, where you say, oh, off you go, or they come in and they say, oh, I've been doing my pelvic floor exercise, my incontinence has gotten worse.
Yes.
Yep. How often have you heard this? And I'm just like, oh, well, sorry, that's what you're supposed to be doing. And, you know, that's what's happening. You know, you've got something that's already too tight or dysfunctional, short one side, and, you know, and now you just do more of the thing that's already not good for it, you know.
100%.
So this is where your work comes in as so important, is that pelvic floor release work, the breath work, the adductor stretching, you know, the understanding where your body is, the posture work. Absolutely, you've got to be able to let go, to contract, and I'll sometimes just take patients completely off pelvic floor exercises for a period of time. And I know it's become this kind of blanket fix, and it's not, because it's not a blanket. Nobody has the same pelvic floor as anybody else. Nobody has
I had a little case study on myself recently when I was launching this women's wellbeing space, and I was working long days at the computer, so way longer than I normally do. I'm normally somebody who's quite active and moves a lot, but I was spending hours at a time sitting and in quite cold environment actually, and I felt around my tailbone this kind of spasm, tightening, but rather than getting up and moving and releasing and doing my breath work like I kind of knew I should, because I had to get something out then and there, I pushed through it, and I experienced a shooting pain down through my sort of piriformis and right down through my leg, and literally it was like my one side, the obturatus internus around there had just gone. It was just this, and I was just on the one side, and it was really interesting because that is still to this day is a weak point. Like I've got to be really vigilant with release work. And I did find that I got a lot more urgency and a bit more urgent incontinence during that period. I really had to pull back myself, stop doing squats, stop doing, I didn't do any pelvic floor work at all around the anus. You know, I had to be quite vigilant about if I was just around the urethra. And it has got better, but I've had to do lots of hip swirling, lots of pelvic opening, releasing, sitting bones widening, pelvis lifted. Yeah, and I'm like, wow, I know this stuff, and it was so.
Yeah, I know. I mean, look, I've got my own issues with my pelvic floor, which I won't share. But you know, you just go like, oh my God, how did I not even know this? You know. So, but I suppose we're learning all the time. What does my Angela say? You do the best with what you know, and when you know more, you do better. You know. So I suppose as a practitioner, constantly evolving, as a human, constantly evolving, and just trying to do better
and be kind to ourselves. You know, like the stuff happens just like that. It's not like, whoa, you're such a bad person and don't talk about it. I really think that it's important to it's always a balancing act. And then when we do get more information, then we can utilize that and we can change. But it's always a slight shift, and we're never perfect all the time.
Yeah, and I think something often that I see with women coming in with prolapse is they blame themselves. Oh, I did this thing. I shouldn't have jumped on the trampoline. I shouldn't have gone for that run. I shouldn't have. But actually, when you start looking at the fact that there were these tension patterns, and we'd step away from the idea that it's the pelvic floor that was weak, because the pelvic floor was strong just a minute ago, and now suddenly it's weak. Is that so? Or is it because there was a tension pattern that the body could no longer cope with, and the only coping strategy for it was for the organ to change position? You know, in that jump, in that run, it had to change position to maintain homeostasis so you could go on continuing to live your life, rather than, stopping you from being able to wee, or stopping you from being able to, whatever you could do. So then you can understand the suddenness of the symptoms sometimes,
But also, I think it's worth, so this is a huge new body of information and new approach, in that, yes, if you have got tension patterns, we need to make sure we're releasing those. But layered on top of that, I think it'd be worth talking about the midlife, the change in estrogen levels, and how that actually changes the integrity of the muscles that hold organs, and the tissues that hold organs in place.
I mean, estrogen is so huge, because if you, it helps to build the muscle. It helps to keep the tissues pliable and relaxed. It helps to, that kind of tension that a muscle can go through. There was a study done some years ago on professional athletes, and with ACL tears, which is a tear in the knee. And the percentage of them that had torn their ACLs in the first day of their period was absolutely huge. Now, why is that relevant? Because on the first day of your period, your estrogen's gone from up there to down there, and suddenly the tissues that could do the thing you did the day before cannot do the thing you did the day before, literally.
And a lot of women getting their shoulder ripping, aren't they, as well? Just playing tennis when they haven't for a while, and doing that right around their period, and then there goes their shoulder.
Exactly. So I think once we understand that the effect of that just on the connective tissue and ligaments and structures and stuff, you go, oh my goodness, now we go through perimenopause or menopause, and you don't want to do that HIIT class you've always done, or that spinning class you've always done, and suddenly your body just says no, because they just needed that estrogen to maybe cope with the demands made for flexibility and strength.
And it's a hard one, because it's only just now really being talked about in mainstream media, and doctors starting to understand new body identical HRT as opposed to the older style synthetic HRT. I know there are still so many women who are very, very wary about going there, and would rather try to up their phytoestrogen, through diet and that, and through supplements. Any comments on diet as opposed to body identical?
I don't think it's as opposed to. I think it's as well as. I think we have to do the diet thing. We have to do the mindful thing. We have to do the relaxation. We have to eat enough protein to help our bodies heal and keep our hormones nice and stable. But there does come a point where it's very, very difficult for you to maintain the level of estrogen just through diet and phytoestrogen. I just don't. really think it's possible. So even if you can keep the level of supplementation of estrogen low in the early years and go up as you run out completely, I think there's going to be a ceiling as to how far you can go with just diet and estrogen. But there will be you can't do it because of whatever reason, whether they just have a thought about it or. But that's my personal view.
So what about, I think worth talking about topical estrogen, estriol for the pelvic floor area? And
so look, that's absolutely safe, isn't it? That's not something that's absorbed systemically. So for women who've got an estrogen sensitive cancer or something like that, they can still use that safely because it's not absorbed systemically. And if you speak to a specialist, you'll know this is the truth. It's safe. But what it's also doing is supporting the musculature of the pelvic floor, the connective tissue of the pelvic floor, the urethral sphincters, that thin out and open up so you leak whether your pelvic floor is strong or not. That's going to happen. So yeah, it's absolutely safe to use because it's a different form of estrogen and it just isn't absorbed systemically, so it's just local in the actual tissues, and you can rub it externally onto the clitoral area, onto the labia, so you get that you have less risk of atrophy in the area where things are pulling back and thinning, so it can be very helpful for all of that.
I always think it's like, ladies, when we start getting like we need a bit of an eye cream, we start getting a little bit jowly in midlife, and actually it's exactly the same down there. We lose the elasticity of the muscle fibers, and especially around the sphincters, they become less plump. It's like when you see women who just become a lot more kind of haggard looking, and we're just less plump. So therefore, by supplementing the estrogen, and it's basically a lack of estrogen, that's what's causing everything to dehydrate. But by putting estrogen cream or a pessary into the pelvic area again, it can just re-lubricate. So it's weird, that's re-moisturize, plump up, and make everything work better. So actually, when we are in midlife, and it's kind of from about 42, 43 for the average woman. Obviously, we're always on a bell curve here, but to use a topical estrogen around the pelvic floor, even if you're not taking systemic HRT in any form, can help the integrity of those tissues and keep everything up. So pelvic organ prolapse can stop it getting worse. It can be a factor in that, can keep the leaking at bay, etc. Can also help with UTIs by just keeping the pH balance of the vagina better and the bladder. But then also, so that's one level. But if you've got pelvic organ prolapse, and especially if you have had an episiotomy or severe tearing or a forceps delivery, then what as an extra layer, what Elrina is just bringing to us today is the extraordinary difference it can be to have myofascial release on that scar tissue. Is that
and a scar almost anywhere in the body, or a dysfunction anywhere in the body.
Okay, so we're not just talking, so we're talking.
They're obviously the most impactful because they're right there and have the biggest pull in that area. So even very superficial scarring. I've had a lady recently just had grazing. You know how they don't call it a tear, it's just grazing. And because it's in her very superficial layers, it's literally tugged and pulled. It's so interesting to see, and we released that in 2 sessions, and her symptoms are all gone.
Wow, so I love that.
Pain, she couldn't have intercourse, too much pain, just couldn't get entry, pain with wearing jeans and stuff because it was hurting her down there.
I'm thinking of a client who I saw recently, who I did say to come see you, but I must remind her to, because what you're speaking of right now, I'm like, wow, it could really help.
It's very much wow. And one of the things that Anna mentioned on the course was something that's been puzzling me for a while, and it's one of those things that you don't really want to mention to your colleagues because you think maybe I'm missing a trick here, and we were talking about something called the Vata-Ana avulsion. So the
Vata-Ana,
so you know what I'm talking about.
Yes,
I'll show you this on the video, but just for those, I'll try and speak through it in a way that those are listening on audio. So you've got your Vata-Ana that attaches at the back of the pubic bone and then sits all the way around the anus. It attaches to the coccyx at the back. So it sits like a little sling all the way through. And you can get, according to common knowledge, and the earth is flat, you can get a tear here. It's called a levator ani avulsion. So it literally pulls away from the bone during birth. And I think it's quite a high percentage of women that have that, maybe 30% or something, postnatally for the vaginal birth. And I get them coming in and I feel the levator ani avulsion. And what I then feel is that the muscle is kind of pulled up to the other side. It's like it's kind of bunched up in one way, as you would with a core muscle. And what you would do is you'd feel behind the pubic bone for a contraction. And if there isn't one, that's how you diagnose. Okay, so one side is okay, one side isn't. And I've actually, in the last year or so, stopped diagnosing them. And I'll tell you why. Because what I was finding is I diagnose it and I do my release work that I normally do. So I'd be releasing on the tissue, I'd be releasing all around, doing everything I normally do. And they come back after 2 or 3 sessions and I do a contraction and suddenly there was no longer a levator ani avulsion.
Oh.
So I'm like, oh my goodness, I've misdiagnosed, you know? And this is happening more and more to the point that I've gone, okay, I'm not going to diagnose it. I'm just going to do 2 or 3 sessions and see how we go. So I would say, look, it feels like there might be something here, but let's see, you know, because in case they never come back to me, at least I've flagged it. If somebody else goes, you know, you've got a levator ani avulsion. And then 2 or 3 sessions later, I go, no, we're good, you know, it's fine. So what Anna flagged is a study they did on the tissue where the tear was supposed to be, you know. And what they found histologically, so that's when you study the actual cells that are there, is the cells were muscle tissue cells. Now, if there was a tear, there wouldn't be muscle tissue there.
Okay, interesting.
Away from the bone, it would be gone, wouldn't it? It would be stuck where the rest of the muscle is. But they were finding that there was muscle tissue there. So I was quite vulnerable. I put my hand up and I said, Anna, this is what I'm finding in clinic, you know. And then about 4 other practitioners went like, are we finding this as well? We're also finding like you think you're diagnosing it, and then 3 sessions later, when you've done your myofascial release work and your breath work and your posture work, all the rest, it's gone.
And is it
interesting? Now that is mind blowing for me because it's something that can never be repaired. They don't do surgery for it, you know.
Yeah, I know. And a lot of women's lives are ruined by it. I mean, really ruined. So are you saying that the cells are literally regrowing? The brain?
No, the cells are still there. So what's happened is the muscle is thinned out and bunched up. Yeah.
Yes.
But when you release it, you release the tension, you allow it to take its anatomical position.
Oh my God.
What we're just talking about, isn't it?
So it's more than the fascia has pulled and bunched as opposed to an actual
muscle
tearing of the muscle.
Yeah.
Okay.
And
so
that's what this is where I've walked around the world a few times and gone, oh my goodness, I think it's round. Everybody else says it's flat and there's nothing to be done about these. I must be misdiagnosing them.
So hang on, are we saying that there is still a percentage of people who do have a genuine literal rip tear of the muscle? Are we I
haven't seen the study myself, but from my clinical experience, what I'm finding is the ones that I think have a tear, once I've treated them, they seem to have unbunched themselves.
Oh wow, that's
but the
huge.
Thing is, I don't know how many I've neglected when I thought there was a tear and I thought there was nothing to be done about it. Do you know?
Oh my God.
Years gone by before I started working the way that I work now.
Amazing. But
and also creating that expectation for a woman going, oh well, this is the way it is, nothing can be done about it, you know, you at a higher risk of organ prolapse later on, and creating that expectation for somebody, which is so unhealthy.
It's amazing. It is, once again, it's speaking to the whole mind-body connection, isn't it? And the homeostasis, that the way the body wants to go back to a whole state when we give it and a lot of it is, and everyone says this, stress and tension are behind so much dis-ease. And what you are doing by releasing some of that bunched up tension, and then by saying things might get better, and what we need to do is add on to that your breath work, your release work, your postural work. And so both the person and the clinician, you are creating an environment for the body to go, oh, thank God, I can just relax.
Yeah, and that is often the thing patients say, isn't it? Like, oh, I feel so much lighter. I feel so much better having spoken to you. Just letting something go, you know, some emotional stuff, or just being reassured about what's going on for them, because it's the fear of prolapse, which is huge because people have this visual that the organs are going to fall out of their bodies, and it's so rare. I mean, I've never seen it, and most clinicians I've spoken to have never seen it, you know. It's not that it doesn't happen, but then you have to go wonder at the tension patterns that that poor woman is going through. You know?
Well, you absolutely, because if you think that things are going to fall out, you're going to be constantly holding and lifting. And I know I've had messages from students who've gone, do I need to contract the whole time when I'm running? I'm like, oh, fuck.
Exactly. No, let it go. And I remember some years doing some training with Professor Ruth Jones. She was like, let it go, soft belly, soft belly, soft belly. And, you know, so I suppose, you know, since I've started training in women's health, and certainly, luckily, my musculoskeletal background with all the kind of biointegrity and fascial trains and all the stuff I've been studying over the years fed into my training and fed into the people that train me training. So even though this is new and exciting research, and some of the training we did is still very flat world, at least I've had that mindset and experience, I suppose, from doing it elsewhere in the body. And Diane Lee, who's a guru, saying it's just musculoskeletal physio in a cave, where you have that mindset, you know, you've got that mindset of like, it's not different, it's not a mystery, it's just in a dark place, you know, preferably wet place. If we put some estrogen in there, oh, we're nice and young. so everything can glide and slide the way it should, you know.
Oh, amazing. Well, guys, I mean, if you're listening to this, you have just listened to some stuff which is really quite revolutionary and really quite mind-blowing and so empowering and so exciting. And if you or anyone you know is suffering with any kind of pelvic floor dysfunction, and especially prolapsed organs, and they're worried about it, they're stressed about it, they're not already on a program or working with somebody for it, then please make an appointment, go and see somebody like Elrina Van Zyl. Make sure that you are addressing it. It's not something that will go away necessarily of its own accord unless you bring some attention to it. And if you need some help on the yoga release opening front, then obviously you're in the right place as well. We've got all of those classes, and
it's absolutely invaluable. Yeah, absolutely invaluable what you do.
Oh, amazing. Well, listen, is there anything that you would like to finish off with? Any messages to the ladies listening today? Anything you'd like to
I think possibly just a bit of self-examination. You know, so often I'm working with women who've never, ever felt how things feel down there. Go and feel with your finger. You've got it at the end of your hand. Does it feel tighter on one side than the other right at the entrance? Does one adductor feel tighter than the other? You know, that inner thigh. When you stretch one way and the other way, does one side feel tighter? You know, because those shear attachments, they're massively impactful. When you stand in front of the mirror, is your one hip slightly higher or more forward than the other? And, you know, can you see that? Can you feel when you go right inside that one muscle, when you do a squeeze, really lifts and the other side really doesn't? You know, this will give you a good indication that you probably do need to see someone, you know? Or even just saying to yourself, you know, if I were to just do a little bit of gentle pressure through there, does it feel different? I mean, often I'm spending 30 seconds releasing a tight area internally, and I ask her to do a contraction again, and suddenly she's got a 5 out of 5, where she had 1 or 2 before. So you don't need hours and hours of therapy on these areas. You know, it can be very reactive very quickly. As long as the surrounding environment, as you say, Linda, is right and it's there, you know. So go and have a look. Look with a mirror. How does it look? How does it feel? Put your finger up there. Go and have a little play.
Exactly. We're going to lift the lid on the whole, you know, tummy button and below being cut off, and have a look. Have a look. We are holistic beings. You know, our women's bits and pieces are quite extraordinary, and we really, you know, we want to embrace the whole body and mind, and it is, everything's so very connected. God, I love talking to you. It's always so fascinating and interesting. Thank you so much for joining me today.
Oh, thank you for having me. I'm going to go and have breakfast and lunch now. I've been running so late today. I haven't managed
Feed the body, feed the vessel. All right. Thank you, darling. Bye.
Bye.